Hello, everyone, and welcome to today's live broadcast, Genomic Profiling in Community Practice, Ensuring the Right Test for the Right Patient Every Time, presented by Pranil Chandra. I'm Alexis Krauss of LabRoots, and I'll be your moderator for today's event. We are delighted to bring you this educational web seminar presented by LabRoots. LabRoots is the leading scientific social educational events and webinars. Before we begin, I would like to remind everyone that this event is interactive. We encourage you to participate by submitting as many questions as you want at any time you want during the presentation. Just click on the Ask a Question box located on the far left of your screen and type your questions into the drop-down box that appears on the screen. We'll answer as many questions as we have time for at the end of the presentation. If you are hearing the presentation, please click on the Help Desk button located in the promotional board at the bottom center of your screen, or use the Ask a Question box to let us know that you're having a problem. This presentation is educational and thus offers continuing education credits. Please click on the Continuing Education Credits tab located in the top right corner of the presentation window and follow the process to obtain your credits. Please join me in welcoming Dr. Chandra. I will now turn the presentation over to him.
Thank you very much for that introduction, and it's my pleasure to be here to speak to you about genomic profiling and our practical real-life experiences in being able to deliver the practice of precision medicine or precision oncology in community practice. One of the things that has been just an absolute pleasure as a practicing physician is to see the growth of precision medicine and the growth of molecular pathology testing in being able to enhance the delivery of clinical care for patients with cancer in community practice. I think it's a very, very exciting time to be a pathologist as well as to be practicing medicine and anything to do even peripherally with the practice of precision medicine. So a little bit about myself. My name is Pranil Chandra. I am a pathologist by training, and I trained at NYU Medical Center up in New York, where I completed an anatomic and clinical pathology fellowship. And that was followed by a hematopathology fellowship. And then 2 more fellowships I pursued at the University of Texas MD Anderson Cancer Center in Houston, where I was fortunate to be function as chief fellow. And it was just a wonderful experience of being able to practice and learn from either leaders or faculty who were on their way to becoming leaders in the various segments of pathology. After which I transitioned to a large practice in Milwaukee, Wisconsin, where I was there for about 2.5 years. I was a general pathologist, but also in charge of a lot of the molecular testing and algorithmic testing that took place in the practice. And I have since then transitioned to PathGroup, where I have been for the past 6.5 years. And in my current role as Chief Medical Officer, I provide clinical leadership to all of the clinical pathology and genomic pathology testing in our practice. So today, what I wanted to do over the course of the next about 30 to 45 minutes is to give you an introduction to PathGroup and our organization, who we are. Then I wanted to talk about our genomic profiling strategy and some of the efforts that we were successful in planning, implementing, and executing in our practice. And then I'd like to get into some real-life case studies just to show how genomic profiling is used in clinical practice in the context of myeloid disorders and acute leukemia. And I'll spend a little bit of time talking about what those disorders are. And really, at the end of the day, I want you all to have an understanding of how we ensure that the right test is delivered for the right patient at the right time. And then there will be some time for interactive discussions and questions, which I also look forward to. So I wanted to take a couple of minutes to tell you about our organization. I'm very excited to be, part of this organization, and it's been just, a wonderful ride during my 6.5-year tenure at PathGroup. And a little bit of history about PathGroup. We are a large and a diverse business and have been in operations for nearly 50 years. We are located in the Southeast, specifically in Nashville, Tennessee. And as you can see from the graph below, we provide the full range of laboratory services in more than 20 different states and more than a 500-mile radius around Nashville, Tennessee. And these laboratory services span anatomic pathology, clinical pathology, as well as molecular pathology, which is an area that we've seen some significant growth over the past 6.5 years since I've been here. We have more than 80 board-certified pathologists and PhD-level laboratory directors with expertise and training in every area of pathology and laboratory medicine that you can imagine, ranging from dermatology to gastroenterology to molecular pathology and precision medicine. We service more than 100 hospitals and ambulatory service centers and thousands of physician offices on a very routine basis. Currently, we have about 90,000 square feet of reference laboratory space based in the Nashville, Tennessee area, where we provide services that support not only our physicians who are medical directors and pathologists at these various hospitals that are part of integrated regional healthcare systems, but also that support our physicians in the thousands of physician outpatient offices. And our practice ranges from bread and butter primary care clinical practice to women's health and infectious disease testing and oncology testing. Women's health and oncology are our two biggest areas of concentration and where we see the most growth, the most testing, as well as the highest number of clients. So essentially, we are one of the largest privately owned pathology groups in the country, and we have a lot of experience and hospital and physician client base representing all specialties. So really, it's been a great practice, and fortunate to say that we continue to grow on an annual basis, and we double in size every 5 to 7 years. So because we are so large in size, we thoughtfully took some steps to invest in the areas that we felt were going to be important for growth. And we started making these plans in 2011, and this was led by a team of folks, including myself and senior executives, as well as scientific and laboratory directors and our physicians. And it's really hard to encapsulate what we did on a slide, but a long story short, it was a series of committed efforts to build an enduring molecular pathology division. And a number of efforts behind that, including recruiting top talent and fostering leadership, building the appropriate culture of innovation, a culture of teamwork, but at the same time, a culture of cost efficiency. And I'll get into later, there is a lot of reimbursement and regulatory pressure on the lab industry. So we have to be very thoughtful and cost efficient in our clinical operations, but at the same time, deliver high value and high quality healthcare services. The other thing that we did was to diversify our test menu and expand our molecular pathology test menu and focus on tests that add value. And what do I mean by value? I mean that these are tests that either improve patient outcomes and/or decrease healthcare costs by informing any combination of diagnosis, prognosis, and/or therapy. And I'll get into some of the tests that we've deployed and launched. But generally speaking, we started with our molecular testing and expanded into genomics. So what's the difference between molecular testing and genomics? Molecular testing traditionally looks at one gene or one genomic region at a time, and genomic testing looks at multiple genes or multiple genomic regions at a time. And we are in an era from 2011 to the present where there's been just an absolute explosion in literature that highlights the clinical utility of genomic aberrations. And it's almost every week and every month that there's a new publication that's out there, and that's starting to really change the practice of pathology, and now requires additional tests in addition to the traditional tests that we utilize as pathologists in our practice. The other thing that we've seen is an explosion of drug development. There are now thousands of targeted therapies that are being used in combination with traditional chemotherapies, in combination with immuno-oncology therapeutics, including so-called immune checkpoint inhibitors, immune checkpoint modulators. So there's been a lot of advances in drug development. And the other thing I wanted to highlight is the fact that high throughput sequencing is becoming more cost effective. You have what's so-called next generation sequencing platforms that allow for more cost efficient sequencing of hundreds to thousands of genes at a fraction of cost that it would take utilizing traditional pathology methods. So all of this has combined together to create a really great opportunity from a clinical and medical perspective in providing genomic testing for our patients. And we saw that a few years ago, and we invested in many of those promising technologies and now have deployed them into our practice across pretty much all of our clinical service lines. And these technologies include high throughput PCR. I'm not going to get into the technical details. That's beyond the scope of today's discussion, but just important to know that PCR is the backbone of molecular pathology testing, first invented and conceived by Kerry Mullins in the early 1980s. And that's translated into just a myriad of tests that have really changed the practice of molecular biology and molecular pathology. And now that's gone to the next level with next generation sequencing. There are PCR-based as well as what's known as hybrid capture-based technologies that allow for next generation sequencing testing on a variety of platforms that are available commercially today. Another high throughput testing technology that doesn't get a lot of attention because it kind of hides in the limelight of next generation sequencing is cytogenomic microarray. And very briefly, that allows us to look at global chromosomal level copy number alterations at a whole cancer genome level in a very cost efficient fashion. And so again, to summarize, we've been successful in implementing all of these tests into our practice. So in the area of oncology, which will be the focus of the remaining slides of my presentation, it's important to know that the focus has often been on the right therapy for the right patient, at the right time. And sometimes that involves looking for that needle in the haystack that, as you can see in the picture on the upper right-hand side, and that's, for example, when we are looking for an ALK mutation in a non-small cell lung cancer. ALK mutations occur less than 3% of cases of advanced non-small cell lung cancer, but we test for the possibility of ALK rearrangements because patients with ALK alterations respond exquisitely well to FDA-approved therapies that are directed against that genomic aberration. Let's talk about the silver bullet. In patients with metastatic melanoma, melanoma was once considered a very, very aggressive disease that was very difficult to treat and cure. But many melanomas have a mutation in a gene called BRAF. And melanomas with a BRAF V600E mutation respond wonderfully well to targeted therapies that are directed against the RAF-ERK MEK pathway or MAP kinase pathway. And there are now FDA-approved BRAF as well as MEK inhibitors that are approved for patients with advanced melanoma that have a BRAF mutation. Genomic profiling may also involve finding the rotten apple. So, this is applicable in metastatic colon cancer, where patients with metastatic colon cancer need to be evaluated for the presence of a mutation in KRAS or NRAS, because if those patients have a mutation in one of those genes, they are not going to respond to a very toxic and expensive, monoclonal antibody therapy such as cetuximab and panitumumab. And so by identifying these patients, you're able to do cost avoidance by testing for the genomic aberrations, and then a clinical decision is made to either place the patient on a regimen that contains that therapy or not. And because these are so expensive, it's been calculated that if every metastatic colon cancer in the healthcare system gets tested for KRAS or NRAS, the savings to the healthcare system is in the order of magnitude of hundreds of millions of dollars. So for these reasons, tests like this that add value to the healthcare system have been adopted and integrated into routine pathology and laboratory workup of various tumors. So I wanted to spend some time talking about clinical utility because the definition of clinical utility differs depending on who is asked to provide that definition. So payers today, now let me go back a slide, are very focused on ensuring that the right genomic aberration is linked to therapeutic benefit. And that's been a big focus on many of the payers, insurance carriers, Medicare, as well as private insurance carriers, and that's great. That is one way that one can derive clinical utility, is to improve therapeutic outcomes. But in the world of precision medicine and molecular pathology, it's oftentimes not just about the right therapy for the right patient at the right time. We have to think about it from a different perspective, and a perspective that is more patient-centric. And so there is utility in establishing a diagnosis, for example, and enhancing the time to reach that diagnosis. And without an appropriate diagnosis, you cannot provide the right therapy for the right patient at the right time. Prognosis is also important in addition to therapy. And so I was fortunate to be part of an effort by the Association of Molecular Pathology to not necessarily redefine what clinical utility is, but to cast a broad light on really the various shades that clinical utility can take on for patients with both inherited diseases as well as cancer. And this was meant to just be an educational opinion review article that just highlights the benefits of molecular testing. It highlights the importance of molecular professionals in delivering precision medicine and empowering the delivery of personalized medicine, but also just kind of refocuses the discussion more from a patient-centric perspective. And the main theme of our article and publication is articulated in this slide, in that number one, that the benefit of molecular testing is not only about therapy, but it's also about diagnosis and prognosis. And that's very important to know when deciding which tests to bring online and which tests are actually going to get reimbursed. The other point that I want to highlight, and this is a little bit more of a practical perspective from my end, is that the diagnosis, prognosis, and therapy are oftentimes related. So let's take some examples of tumors. And in a bone marrow-based disorder like myelodysplastic syndrome, oftentimes you use the molecular test to establish a diagnosis and use it in conjunction with the clinical and the morphologic and all of the other laboratory tests, which may include genomics as well, to provide a more precise diagnostic classification. And the latest publication, and actually the Bible for hematologic malignancies and lymphoid tumors, that's published by the WHO, there are now a myriad of genes, and some of which are required for diagnostic classification of myeloid stem cell disorders. Sometimes you may have a tumor that is widely metastatic, and there is it's difficult to pinpoint where that tumor is coming from, and some of these molecular tests can actually help pinpoint that this is actually a tumor of a GI origin, and that is going to have downstream implications with regard to therapy. Okay, so again, diagnosis and therapy are often related. Same goes with prognosis. So if you have you've made a diagnosis of a myeloid stem cell disorder, and some certain genomic aberrations will tell you, and will tell a patient who's asking their doc, what is my prognosis? Well, certain aberrations will tell that this is either going to behave indolently, or it's going to fall somewhere in the middle, or it's a tumor that's going to behave very aggressively, right? And so, for example, in a myeloid stem cell disorder, where a patient is going to have an aggressive clinical course, there are aggressive therapeutic regimens that can be considered, which include but are not limited to bone marrow transplant. And then therapy. We've talked about therapy, and in the context of myeloid disorders, now there are FDA-approved therapies for genomic aberrations, including IDH2 in acute myeloid leukemia and FLT3 in acute myeloid leukemia. And patients with these aberrations have been shown to benefit from therapies directed against those genomic aberrations. So again, getting back to the paper, the point was just to highlight and broaden the scope of clinical utility and the positive impact that molecular tests have for patients. So in our practice, we took that to heart, and our goal was to be able to provide any test for any patient at any time. And so we took the liberty to make sure that that we had a test that could be applied for any patient with any cancer. And so this is a very simplistic summary of all of the different assays that we have. And essentially, for any patient with a cancer, whether it's initially a diagnostic time point or it's an advanced cancer, we designed panels and tests that use complementary technologies that are specific to the clinical as well as histomorphologic context, ranging from single genes. We've got more than 35 different genes and genomic regions that we could test for singly. We've got very basic panels, and then more disease-specific panels for common cancers such as colon cancer, lung cancer, and solid tumors, as well as hematologic malignancies such as myeloid disorders and chronic lymphocytic leukemia. And then we have broad panels that would be similar to the ones that are offered by Foundation Medicine, and where you're casting a broad net. And those tests are usually used in patients that have refractory advanced disease where they've failed standard line therapies, and they're looking for a genomic target and potentially being placed into a clinical trial. In our practice, the selection of the molecular tests is very much dependent on the clinical and morphologic context. And very often in our pathology practice, the test that is selected is driven by pathologists who are rendering diagnoses under the microscope. The image that you see here on the left is essentially what a tumor looks like under the microscope. And this is an example of a follicular lymphoma. It's a hematologic malignancy, and just from personal recollection, this is a high-grade tumor. And based on that context, based on decisions that are rendered at the microscope, that leads to downstream decision-making and a utilization of one of these core technologies that I've listed here, such as immunohistochemistry, flow cytometry, cytogenetics, cytogenomics, FISH and site to hybridization, simple PCR, sequencing, ranging all the way up to next generation sequencing and gene expression profiling. Depending on the clinical context, that drives a set of downstream decision-making points to arrive at the right diagnosis and render clinically useful prognostic as well as therapeutic information. And you can see here that next generation sequencing and cytogenomic microarray and some of these high throughput technologies are just one of the many tools that pathologists utilize in order to work up tumors to render the appropriate diagnostic, prognostic, and therapeutic information. So here's another tumor. This is an invasive colon cancer. And this is an H&E slide and an example of what a pathologist would see under the microscope. And, based on a decision that renders this diagnosis, pathologists might, utilize immunohistochemistry to make sure that it's, of colon origin, and then use other technologies depending on if this is a colon cancer initially at diagnosis. And if it is, then you have to do Lynch syndrome testing, which requires immunohistochemistry, as well as microsatellite instability testing. If this is a metastatic colon cancer, then we may do KRAS, NRAS, BRAF testing to, according to NCCN guidelines, define prognosis as well as potential response or lack thereof to therapy. And if this is a widely metastatic colon cancer, then you may want to do a broader genomic profile that looks for certain alterations like HER2 amplification, and patients with advanced metastatic colon cancers with HER2 amplification, for example, stand to benefit from a number of clinical trials that are available today. And this is an example that I show here of an invasive lung cancer in a patient with advanced stage disease, where it's standard of care to work a tumor up with a thoughtfully selected immunohistochemistry panel. And then, it's important, according to NCCN guidelines, to look at alterations in genes, including EGFR, ALK, ROS1, BRAF. Again, invasive non-small cell lung cancer. Again, if this is a widely metastatic non-small cell lung cancer, you might want to cast a broader net. So again, just wanted to highlight, the workflow, how diagnosis is rendered, how it leads to downstream decision-making and test utilization. And then on the next slide, our workflow here in our practice, we have custom-built tools that help pathologists and molecular pathologists interpret all of the changes in DNA, RNA, and protein in conjunction with the clinical and morphologic context, and interpret that in the context of what's published out there in the literature, and as well as what's present in genomic knowledge bases. And we've built clinical informatic analytic tools that help us render the diagnostic and prognostic as well as therapeutic information, and integrates all of that through integrative reporting. This is an example of one of our integrative summary reports. And as you can see in the results section, what we do is we summarize the results from all of the different technologies that are utilized to profile a tumor. Then there's an interpretation that's written by either myself or by one of my teammates who may be a physician or an appropriately trained PhD lab director, and then the report is signed off by a physician, molecular pathologist that's board certified, and then an articulation of the therapeutic associations, as you can see on the left-hand side, an articulation of the prognostic associations in tabular format, and then wherever appropriate, clinical trials. Clinical trials are very important, and some clinical trials may significantly improve the outcome of patients with both localized as well as advanced cancer. So incorporation of clinical trials and examples of clinical trials are things that in the appropriate context we also include in the report, and then there's a list of references. These reports are usually 1 to 2 pages long. We want to be able to present them in a lucid format that is educational, that's not overly burdensome for the end user and oncology client, but will give them enough information to give them an idea of the molecular biology of the tumor, and then start to articulate and map out next steps and treatment steps based on diagnostic, prognostic, as well as other information that's rendered in the reports. That's an example of the report that we've designed, and we're taking a lot of thought, and we continue to get feedback and are looking to take this reporting to the next level. So our strategy, fortunately, has paid off, and I wanted to show this slide here for a couple of reasons. I wanted to show you results of our efforts from 2011 to 2017, and this is just in the area of PCR and next generation sequencing testing, which is just one part of our molecular pathology practice, but indicative of just the amount of growth and demand of molecular profiling in cancer patients, molecular as well as genomic profiling. And as you can see here, in 2011, we didn't have a lot of assays. Every color that you see here represents a new assay that we've introduced and deployed, validated, and developed, validated, and deployed into our practice. And every color here you see represents a new assay, and it's color coded, and highlights the importance of test menu diversification, but also highlights the demand for molecular testing and genomic profiling, and the continued growth based on all of the publications and all the new literature that's coming about in this area. So I will also say that most of the tests that you see here, at least in our practice, have been this single gene test and the focused, profiling, because, they're well defined. They're defined by NCCN guidelines and high impact publications. And most clinicians and oncologists know what to do with a KRAS or a BRAF or an NRAS mutation in metastatic colon cancer. And so in community practice, we see a lot of just single, a la carte ordering, as well as, more focused profiling. And again, when you look at a cancer patient at the point of diagnosis or metastatic disease, or if they have relapsed refractory aggressive disease or very advanced disease, it's important to think of those cancer patients across this diagnostic and therapeutic continuum. So that's what we see today. And then in relapsed aggressive tumors, we're seeing broader utilization of broad panels. And we see, tests that get sent out for Foundation Medicine. Some of those tests we do, and there are other commercially available tests that are available in addition to ours and the other organizations that I mentioned. Now that's the practice today. I will say that this is going to change over the next few years because of this continued explosion of genomic information and identification of clinical utility. We're going to see therapies approved agnostically, to tissue site of origin, and some recent therapies, pembrolizumab comes to mind, has been FDA approved for any metastatic solid tumor that demonstrates evidence of microsatellite instability, which can be measured by either PCR or next generation sequencing techniques. And then you have other biomarkers like tumor mutational burden and NTRK fusions and just a whole slew of other alterations where it doesn't matter what tumor it is, it's important to identify those genomic aberrations. So as the field matures, as the literature matures, we're going to see more and more broader genomic profiling over time. The other thing that we're going to see is an increase in liquid biopsy testing. We're seeing this today. And I think that there's going to be a happy medium where when a tissue biopsy isn't available, or when there needs to be additional information in addition to the tissue biopsy, that we're going to resort to so-called liquid biopsy. And these are commercially available tests that are non-invasive, that are performed on peripheral blood and look for mutations in peripheral blood. And there are advantages and disadvantages to that. Obviously, tumor has to be advanced enough to shed tumor DNA in the peripheral blood so that you can pick it up by a commercial software. But also, combination of approaches may address an issue of tissue and molecular heterogeneity, which is essentially the fact that one tumor may have, in a patient with a widely metastatic cancer, one site or one of those tumors may have a certain molecular signature, and another site may have a completely different signature that's similar sometimes, but can also be completely different. And so that can be a challenge in the workup of patients with cancer. And I think with liquid biopsy testing and broader genomic profiling and complementary testing approaches, we're going to be able to overcome that and again continue to render diagnostic, prognostic, as well as therapeutic information. The therapeutic decision making can be placing a patient on a chemotherapy or not, a targeted therapy, immuno-oncology therapeutics, and a clinical trial. And we'll get more into the reasons for why that's important later on in the discussion. So what I'd like to do is now get a little laser focused and talk about myeloid disorders and acute leukemia. Just a brief background on myeloid disorders. These can include chronic as well as acute myeloid diseases, which are generally bone marrow genomic-based diseases and the diagnosis is rendered usually either in peripheral blood, but more often by doing a bone marrow biopsy and looking at the cells under the microscope. And these diseases range from, on the chronic side, myelodysplastic syndrome, myeloproliferative neoplasms, overlap myelodysplastic, myeloproliferative neoplasms, and they can be low grade or they can be high grade. And then those disorders tend to gravitate to and evolve into acute leukemia, which is a medical emergency, and these patients need to be hospitalized and they need to be treated with chemotherapeutic regimens, which may or may not be directed against genomic aberrations. So in our practice, again, we have implemented algorithmic test utilization. And when a client sends us a bone marrow sample to work up, or any tissue biopsy sample to render a diagnosis of a hematologic malignancy, there's a box that they check off, and that allows us to appropriately work up the case utilizing what's recommended in guidelines, ASH guidelines, NCCN guidelines, WHO guidelines, in accordance with the clinical and histomorphologic context by one of our physicians that's board certified. And again, all the results are placed in a comprehensive report that's integrative, similar to the report that I outlined earlier. And we've developed these algorithms based on high impact publications, NCCN guidelines, some of which I'm going to review with you in the next few slides. And it's important because all of these different technologies really plays a part, the traditional laboratory technologies as well as the advanced genomic profiling technologies, they all have a role to play in the appropriate workup of myeloid disorders and acute leukemia. And that was the focus of our publication that was presented and published rather in October of last year. And what we did was we took a few hundred of our myeloid disorders that were worked up by our group, and then in partnership with an oncology group based here in Nashville, Tennessee, and other contributors, and we looked at the clinical utility that advanced genomic profiling techniques add to the standard workup of these myeloid disorders in acute leukemia, utilizing traditional pathology technologies. What do I mean by traditional pathology technologies? Immunohistochemistry, conventional cytogenetics, FISH testing, single analyte PCR testing. How do those stack up compared to high throughput genomic profiling technologies like next generation sequencing and cytogenomic microarray? That was the focus of the paper. We looked at hundreds of cases where we worked those tumors up, with high throughput technologies. And one of the main points of the paper is articulated here. In those cases where there was clinical or morphologic, histomorphologic, pathology-based suspicion of a myeloid disorder, 227 of those that were negative by traditional pathology techniques such as conventional cytogenetics and FISH, and sometimes single analyte PCR. The next generation sequencing and cytogenomic microarray was positive in 76% of those cases. So in 76% of those cases, there was information that was rendered that either had diagnostic, prognostic, and or therapeutic significance. And that's how we defined clinically actionable alterations in this paper that we published. 3/4 of the cases that were negative by traditional techniques were positive. So does this mean that you don't need to do the traditional techniques and you only do the high throughput techniques? That question is answered in the following slide. What you see here is a distribution of abnormal cases based on technologies. In red is next-generation sequencing. In green is cytogenomic microarray. And blue and purple are the traditional techniques, conventional cytogenetics, and FISH testing. And you can see, and this is distributed across all the different diseases: acute myeloid leukemia, myelodysplastic syndrome, MDS, myeloproliferative neoplasms, overlap myelodysplastic, and myeloproliferative neoplasms. And you can see that the detection rate of aberrations is either equivalent or superior to traditional pathology techniques across all of the different disease states, with the highest difference noted in overlap myelodysplastic myeloproliferative neoplasms, including CMML, which is a disease known as chronic myelomonocytic leukemia, and myeloproliferative neoplasms. I mean, but you can also see in acute myeloid leukemia, for example, that next-generation sequencing is positive 86% of the time, as compared to 52% of the time that FISH is positive. Now, what we also saw in our practice were that there were a select number of cases that the traditional techniques, conventional cytogenetics and FISH, yielded the appropriate clinically actionable information, whereas the other tests were non-contributory. When we see that most prominent in another disease state that I don't include here, but the point that I'm trying to make is that every one of these tests is important in the routine workup of patients with myeloid disorders and acute myeloid leukemia. And in those cases where, let's say, FISH was positive and next-generation sequencing or cytogenomic microarray was positive, there was additional information that was rendered. So you may have a patient that would have been classified a certain way, either from a prognostic or a diagnostic standpoint, but the additional layer of information that was rendered by these high-throughput techniques would have changed either the prognostic classification or the diagnostic classification. And I'll get into a couple of case studies that highlight that more prominently. So those were the two themes of our paper, and it's available. It was published in Cancer Genetics. It was published in October of last year, and it drove a lot of the algorithmic decision-making and how we work up these tumors routinely in our practice. But I will say that there's been just a plethora of publications. And, the one that I've illustrated here on the left-hand side, it was published in 2012, and it's been 6 years since that was published, but it highlights a very important point that I wanted to bring out here. And that was the enhanced prognostic risk stratification of genomic profiling to better render diagnostic, prognostic, and therapeutic information for patients. So in the traditional model where you don't do genomic profiling and you do the traditional laboratory tests in patients with acute leukemia, you can see on the left-hand side through the cytogenetic classification that 19% of your patient cohort fall into a favorable risk category, 63% fall into the intermediate, and 18% into the unfavorable. So you've got a pretty uneven distribution of patients into the favorable, intermediate, and unfavorable risk category. You add in molecular testing and genomic profiling, and you can see that your prognostic classification, which drives downstream therapeutic decision-making, changes. So your favorable cohort went from 19% to 26%, and your unfavorable went from 18% to 39%. And so you've taken patients who would have been lumped into kind of this waste bucket intermediate category, and you've identified and reclassified those patients into them either having a favorable or an unfavorable clinical course. And there's another article that was published in 2016 that takes genomic profiling to the next level and really provides an integrated classification based on clinical variables, demographics, copy number alterations. Again, copy number alterations are alterations detected by cytogenomic microarray, and fusions, point mutations, that may be detected by next generation sequencing, and provided an integrated classification. And you can see that integrating the genomic profiling has a much better outcome of being able to better classify these diseases, which again drives the diagnosis, the prognosis, but also drives therapeutic decision making. And I encourage you all to read all of these papers, and there are a plethora of them in myeloid disorders and acute leukemia, and these are just a couple of them that I've mentioned here, for purposes of our discussion today. Again, this paper divided acute leukemias into at least 9 different genomic categories. It might be more than 9 different categories, but based on the genomic aberrations that had prognostic as well as therapeutic implications. Because of all of these publications, now the NCCN guidelines have evolved over the past few years. And in the setting of myeloproliferative neoplasms, you can see here that now there's more than a handful of genes that are important to identify because it changes the prognosis in patients with these disorders. Take this gene AXL1, ASXL1. A mutation in that gene, doesn't matter what myeloid disorder you have, patients with mutations in that gene are almost universally associated with an aggressive clinical course, high likelihood of therapeutic failure, and a high risk of transformation to acute leukemia. Same goes with myelodysplastic syndrome. These are recent NCCN guidelines for myelodysplastic syndrome. And you can see here that there's more than 15 genes that are important potentially in the workup of myeloid disorders. So in a context where traditional techniques are negative and you employ high throughput technologies, either next-gen sequencing or microarray, and you detect a mutation in one of these genes, in the appropriate context, it actually helps to make the diagnosis. By itself, it doesn't make the diagnosis, but in the right clinical and the right morphologic context, detecting these mutations supports that diagnosis. But more, equally important, there's prognostic information that's rendered. And for patients with high-risk myelodysplastic syndromes, where standard therapies aren't working, they may be considered candidates for bone marrow transplant. And it's important to know that bone marrow transplant, it's an expensive medical procedure. It's fraught with complications, and there are also now genomic aberrations that will give a clinician a red flag that this is a mutation that's actually associated with a poor outcome in those patients that are transplanted. So there's a lot of opportunity for cost avoidance and being able to ensure that the right therapies match to the right patient at the right time. And the folks that wrote the acute myeloid leukemia guidelines, NCCN guidelines, were smart. They didn't list all the genes because there's so many genes now that are important in the diagnostic classification and rendering prognostic information and or therapeutic information in acute leukemia. So I'll just read out loud here the NCCN guidelines for acute myeloid leukemia. They recommend bone marrow with conventional cytogenetics. That's a traditional pathology technique, conventional karyotyping plus or minus FISH, and molecular analyses to include KIT, FLT3, NPM1, CEBP alpha, and other mutations. And when you go to the American Society of Hematology guideline recommendations that were recently published, there's a growing list of genomic aberrations that are important to identify in the routine workup of these tumors. So again, lots of literature out there that's now being integrated into evidence-based guidelines, including NCCN, WHO, and guidelines by American Society of Hematology for acute myeloid leukemia. So what I'd like to do is I wanted to talk about some cases that are important to illustrate the clinical utility. This is a 71-year-old who had a high white blood cell count. And I won't get into the details. I'll give you, the main points of what I'm trying to articulate on each slide over here. This is a photomicrograph, low-power view of the peripheral blood. There's a lot of cells that you can see here. They are white blood cells. They are granulocytic cells. On higher power, here you can appreciate that they are granulocytes. Many of them are so-called left-shifted, which means that they are not mature. They're not completely immature. They're not, blasts, but they are stuck in the middle of being, mature white blood cells and immature, white blood cells. And there are some changes that you see here that a pathologist would call, atypical. There's cytologic atypia. I wouldn't say there is frank dysplasia, and that's important in the additional workup of these tumors. This is an example of a bone marrow biopsy. This is what hematopathologists like myself see under the microscope. The very light pink tissue that you see here is bone, and then the cells with the purple nucleus, those are all of the cells in your bone marrow. And what we're supposed to tell when we're looking at these slides under the microscope is how cellular is the bone marrow. And that's based on the amount of fat cells, which are the white spaces that are most best appreciated on the upper left-hand slide. The circular white spaces are fat cells, and all of the other purple cells are the bone marrow cells. And so this is a very hypercellular marrow and indicative of a myeloid stem cell disorder. Just to summarize the testing that was performed, the conventional testing, pathology testing, including single gene analysis, they were all within normal limits over here. A pathologist who looks at this, the first thing that comes to mind in the differential diagnosis is chronic neutrophilic, chronic myelogenous leukemia, CML. And the tests were essentially excluded that because there was no BCR-ABL or Philadelphia chromosome that was detected here. Rather, there was a CSF3R mutation that was detected, and as well as an SRSF2 mutation. There were also some changes that we saw on cytogenomic microarray, which I won't get into the details. So that completely changed the diagnostic considerations, and the differential diagnosis now included chronic neutrophilic leukemia, which is a mimicker of CML, but it's a very different disease on a molecular biology level. And the other differential diagnosis was atypical CML, and the diagnosis for that is rendered when BCR-ABL is negative and you've got evidence of dysplasia. I mentioned that we did not have dysplasia, so we were able to exclude that, and the diagnosis in this case was chronic neutrophilic leukemia. Now, when you look at the literature out there, less than 200 cases, and this is a few years ago, were reported worldwide. And I've got a comment that'll speak to that later on in one of my slides. But first, what I wanted to do is articulate what's the clinical utility, what's the clinical significance. Well, we were able to render a more precise diagnosis. And in fact, CSF3R mutation is required by the WHO as a diagnostic bullet point to help establish a diagnosis of chronic neutrophilic leukemia. So it's required for diagnosis. These tumors usually have an aggressive clinical course. They do not respond to BCR-ABL inhibitors that are typically used to treat Philadelphia chromosome positive chronic myelogenous leukemia. So they tend to have an aggressive clinical course, and patients wind up succumbing to their disease. Now, the literature has showed that depending on the type of CSF3R mutation, that activates a different molecular pathways for which either JAK-STAT inhibitors or SRC-LIN inhibitors may be affected. And this particular mutation is known to activate the JAK-STAT pathway, and so you've got drugs like ruxolitinib that are FDA approved in other disease states that are now being utilized, in an investigational clinical trial context for patients with this mutation. And so again, different diagnosis, different prognosis, and a different therapy that was rendered from the genomic findings. The next case is a 76-year-old gentleman with anemia, and had an anemia and a clinical presentation that raised the possibility of myelodysplastic syndrome. The morphologic findings that are summarized here, they would support a diagnosis of myelodysplastic syndrome, and there were changes, which I'll show on the next slide. And there was another finding of ill-defined lymphoid aggregates. So what does that look like? Here are the pathology images. On the left-hand side, the left photomicrographs show a hypercellular marrow, and the bottom left shows nuclear changes affecting the erythroid, the red blood cell, the white blood cell lineages that would indicate clinical and morphologic evidence of myeloid dysplasia. On the right-hand side, you had these lymphoid aggregates. Those blue cells that you see here are lymphocytes. They are atypical in that they kind of all look like each other, and the aggregates are ill-defined. You can't draw a circle around it. It's kind of insidious in how it's infiltrating into the bone marrow. If you go to the next slide, again, the conventional technologies and laboratory tests were negative and/or non-diagnostic. And in next-generation sequencing testing that was performed, we found 3 mutations, and I'm going to get into the diagnostic, prognostic, and therapeutic significance. This required a phone call with the clinician to talk about and walk through the clinical utility of the findings. So the first thing is that we were able to confidently render a diagnosis of myelodysplastic syndrome, and some of the mutations were actually associated with an aggressive clinical course, and there are molecular pathways that are altered, as well as therapies that are in various stages of clinical development that could potentially be utilized in this patient should standard therapies not work. But the other really fascinating thing was that we made a second diagnosis of early lymphoplasmacytic lymphoma. It turned out that this patient had some other clinical findings, including an IgM gammopathy that would indicate, early lymphoplasmacytic lymphoma. But we also found a MYD88L265 mutation, and then in conjunction with the lymphoid aggregates that I showed you earlier, we were able to let the clinician know that this patient actually has a second malignancy. And really, it was just game-changing. Not only were we able to render one diagnosis, we were actually able to render 2 diagnoses. And so these are some results that I wanted to share in our workup of acute myeloid leukemia. The first case shows that you've got a patient with acute myeloid leukemia with a JAK2 mutation, and you wouldn't think that you would see that in a patient with acute myeloid leukemia. JAK2 mutations are actually diagnostic for many chronic myeloid disorders. But in this case, what this tells us is that this is a patient that actually had an underlying myeloid disorder, and then their disease took off and became an acute leukemia. And that's important to note because these patients actually do not do very well with standard induction and consolidation chemotherapy. There's a high degree of resistance, a high degree of relapse, and there are now actually FDA-approved therapies that are more aggressive. Well, they're better applicable for patients with aggressive AMLs, and one such therapy has been FDA-approved for AMLs with underlying myelodysplasia-related changes. So again, there's diagnostic, prognostic, and therapeutic information that's rendered. The case below, same thing. you had a mutational profile that suggests an underlying myeloid stem cell disorder. But as you can see, that we also found an IDH2 mutation, and now there's actually an FDA-approved therapy that can be utilized for an AML patient, with this mutation. So again, these are just two cases where the testing, really, changed the potential outlook for the patient, but also changed potentially the clinical management decision of the patient. This is one of my favorite cases. This is a 55-year-old with CML that evolved to precursor B-cell acute lymphoblastic leukemia. We did the genomic profiling, and we found a number of mutations that I articulated over here. So it was very interesting because the mutation in the gene ABL1, we were able to go to the genomic databases and the literature and the NCCN guidelines, and there was enough literature to suggest that this leukemia, this particular acute leukemia, would respond to a drug known as ponatinib. And so the patient, was placed on ponatinib, and within weeks, this patient had just an amazing response and was able to eradicate the tumor cells from their bone marrow. And what's also really great is that this is a patient with an acute leukemia that has other aberrations as well. As I mentioned before, IDH2 mutations, there are now very effective therapies that both IDH inhibitors as well as BCL2 inhibitors that have shown promise in acute leukemias with IDH1 or IDH2 mutation. So now the oncologist has a map of, here's how this patient is going to be treated, but in the event that the patient does relapse, I've got option number 2 and potentially option number 3 in my back pocket. And it's just really exciting for patients that with these aggressive tumors to have some very favorable options. I'll just summarize by saying that that myeloid disorders and acute leukemia are on a continuum. And it's really important to know that from a molecular biology level. When you look at a disease like myeloid dysplastic syndrome on the left-hand side, there are certain genes that help tell you that it's gene mutation that help tell you that it's a myeloid dysplastic syndrome. And any of those diseases, whether it's myeloid dysplastic syndrome, essential thrombocythemia, polycythemia vera, primary myelofibrosis, any of these diseases can evolve to acute myeloid leukemia or acute lymphoblastic leukemia. And on the right-hand side are more myeloproliferative neoplasms and then overlap myeloproliferative myelodysplastic neoplasms. And when you've got a patient with an AML, you have to design a testing strategy that incorporates all of the genomic aberrations that you can see in all these other diseases, because if you pick that up in the AML, you can oftentimes tell where that AML came from, and whether it's a de novo AML or it's an AML with underlying myeloid and myeloid dysplasia related changes, it's really important to make that distinction because it has therapeutic impact. So I wanted to leave you just with that notion as the major theme of myeloid disorders. So running short on time here, just to summarize, there's an absolute robust growth in molecular testing. And I think this is going to continue for the foreseeable future. And I think laboratories like ourselves are looking at ways to diversify our test menu and with a focus on clinical utility and on tests that really move the needle for patients. I will say that there are significant headwinds and challenges. It is a competitive market. There are a lot of commercial labs that are out there. There's also a lot of reimbursement and regulatory pressure, which has led many laboratories, including ours, to focus on cost-efficient laboratory operations. I am optimistic that the reimbursement and regulatory challenges will be overcome. as more and more literature supports the clinical utility, as we take our lens off and look at clinical utility from a patient-centric perspective, I think the future is very bright, and it's a really exciting time to be in this field and in the field of precision medicine and precision oncology. So I wanted to thank you for your time. As you can tell, I'm very passionate about this topic, and I'm very excited for where the field is going to go over the next few years. And I think there are challenges, but those will be overcome with time. So thank you again, and I'll be happy to take questions.
Thank you, Dr. Chandra, for that informative presentation. We will now start the live Q&A portion of the webinar. If you have a question you'd like to ask, please do so now. Just click on the Ask a Question drop-down box located on the far left of your presentation window. Type your question into the box that appears on your screen and click the Send button. We'll answer as many of your questions as we have time for. So let's get started. Our first question is, what are the opportunities and challenges for reimbursement?
Well, that's a great question. It's a bit of a loaded question. So let me start with the challenges. I think the field of molecular pathology with regard to cancer genomics is relatively new, and the literature has really exploded over the past few years. And the payers have a bit of time to catch up and really understand the value that this testing brings to the care of patients. There are many molecular tests that are reimbursed, but there's also many molecular tests that face reimbursement challenges as well as pressure. That being said, over time, once we see more data on outcomes as well as other metrics like time to render a diagnosis or establishing the right diagnosis, which drives the right prognostic classification and ultimately therapy, those are all interconnected. As long as we continue to focus on that and the clinical utility, I think that we will overcome the reimbursement challenges. Ultimately, what we need to do, and I see this as an opportunity, is to tie the molecular testing to downstream healthcare costs. And so when you are able to render a test that lets a clinician know that a multi-$100,000 therapeutic regimen is not going to work, that's a lot of cost that you've avoided. And when we can, come full circle and, capture all of that, we'll realize the true value of molecular testing.
Our next question is, why should payers reimburse for testing that places a patient onto a clinical trial? Would that be considered experimental?
A great question, and let me rephrase the question. So if you're performing a molecular test and the patient then decides to place a patient on a clinical trial, well, isn't that experimental? So or investigational? Why should a payer potentially pay for it? And there are a number of reasons. One is that yes, the clinical trial, and there are numerous clinical trials that are out there, both in academic medical centers as well as community practice. The clinical trials are investigational. However, the tests that are utilized by clinicians to find these targets, next generation sequencing tests, they are very well validated according to rigorous standards. Some of these may be FDA approved. Vast majority of them are approved and regulated by CLIA-CAP standards, which is ultimately regulated by CMS. And most laboratories have to perform very stringent efforts to be able to offer a test. And I won't get into the details, but it involves things like ensuring analytical and clinical validity, and making sure that the test is precise, it's reproducible, and all of that needs to be worked up in validation summary that's signed off by a laboratory director. So there's a very robust process already in place that allow for the provision of genomic tests in accordance with evidence-based guidelines by society's preeminent medical societies. So the test is actually not investigational. It is a clinically validated and a test that is clinically meaningful and when utilized responsibly in the appropriate clinical and morphologic context. Second thing I wanted to say is that oftentimes, and NCCN guidelines says this as well, is that the best chance for patient survival can oftentimes be in a clinical trial. And so, that's kind of a bit of a mindset because we often think of clinical trials as being applicable only to a patient that has failed like 3 therapies. But no, there are a lot of promising clinical trials utilizing targeted therapies and immuno-oncology therapies that a patient may benefit from. And to be eligible for those clinical trials, they may need to have a certain type of genomic aberration that's detected by one of these technologies.
And Dr. Chandra, it looks like we have time for one more question. Where do you see genomic profiling headed in the next 5 to 10 years?
Great question. It's hard to predict the future. At least what I've seen in the past 5 years, if that's a harbinger for what things are going to be in the next few years, we can use that as a potential model. I see genomic profiling continuing to get integrated into the practice of pathology and laboratory medicine. I focus today on hematopathology, myeloid disorders, and acute leukemia, where this testing has become integrated and has become standard of care. We're going to see this across all of the other different areas of pathology, from GI pathology, all of the surgical pathology subspecialties like thoracic pathology. We're starting to see that integration today, and that's going to continue over all of the surgical pathology disciplines. And then there's also going to be integration across clinical pathology disciplines. In the setting of microbiology, for example, there are now a lot of molecular techniques that have become standard of care, and that's going to continue to grow. And we're also going to see a blurring of what was originally, traditionally anatomic pathology, what was clinical pathology, what's molecular pathology. There are going to be, tests that and efforts that are going to span really all of those areas and blur the boundaries, between them. And I'll just conclude by saying, there's recent literature, for example, on, the microbiology signature, also known as microbiome signature in your gut, in your stomach and your intestines. And that signature actually can help predict who's going to respond to a immuno-oncology therapeutic directed against a cancer. And, things like that are mind-blowing, but that's the way that, the field is, evolving. And so I think the future is bright. I think that we've got to engage, educate all of the stakeholders, including the payers, and ultimately, focus on, the tests that are going to add the value by, again, decreasing healthcare costs and/or improving outcomes by rendering diagnostic, prognostic, or therapeutic information.
I would like to once again thank Dr. Chandra for his presentation. I would also like to thank LabRoots for making today's educational webcast possible. Before we go, I want to let everyone know that today's webcast will be available for on-demand viewing through July of 2018. You will receive an email from LabRoots letting you know when this webcast will be available for replay. Please share that announcement with your colleagues who may have missed today's live event. That's all for now. Thank you for joining us, and we hope to see you again soon. Goodbye.
Thank you.